Okay, so let's get back to it. This table is also found in your book. So if we look at this a minute, we can kind of see where this comes from. I started a list. This is not all inclusive in itself, but I want to play with the list and see if you can kind of figure this out. The laceration, contusion, and hematomas to the scalp. Somebody over here on this side of the room said that. We got swelling, it's something hit your head. Soft area or skull depression on palpation. Palpation means I touch it and I feel a soft area or depression. Guess what I do then? Stop touching it. Do I bandage it? Sure. So I put a dressing on it and a bandage, but I use a bandage that does not apply direct pressure. Did y'all get the donut thing that day? Making a donut out of a cravat? Using that donut to go around the soft spot so I don't put direct pressure onto it? Okay. Visible fractures, decreased mentation or confusion. We called that altered LOC, didn't we? This one, irregular breathing pattern. Talk to me. See if you can remember this. Why do I get an irregular breathing pattern? Anybody? It's going to go hand in hand with the next two.
You're not getting oxygenation.
Huh? Well, let's skip that for a moment. Let's try this. Widening pulse pressure. You're going to be so mad when I put this on the board, because I've put it up there once. Slow heart rate. Somebody said compensating.
Yeah, I knew.
So these three are all compensatory mechanisms. These are three things that the body does. Three things that the body's doing to try to compensate for the ICP. Collectively, those are known as Cushing's triad. These 3 bullet points, if I was to highlight those out, those are Cushing's triad. Let's take them one at a time. The irregular breathing pattern. Do you remember me telling you that the lower the CO2 level gets in the blood, the smaller the diameter of the vessels get?
Start breathing.
So the body will breathe real fast to get rid of CO2 to try to shrink the vessels. If I shrink the vessels, I allow more room in the brain. But the body says I can't blow off too much CO2, so it'll blow it off and then it'll pause. And then it'll blow it off again and get deep and fast, and it'll get slow and shallow. Deep and fast, slow and shallow. Luke, we have a name for that. That's called central neurogenic hyperventilation. It's called Byett's respiratory pattern. Central neurogenic head hyperventilation. That the word makes sense, doesn't it? Central neurogenic hyperventilation. The EMT textbook just says irregular breathing pattern. I point this out because we got to do this assessment, and you walk up to them and they're going, you're like, what the hell is that? Central neurogenic hyperventilation, Luke says. The body is trying to rid itself of excess CO2 to decrease the lumen diameter of the vessels. Therefore, I allow for more room in the brain, decreasing ICP. But the body says I can't go without the homeostatic range of 7.35 to 7.45 on the acid base. And so you're going to put a capnography on them, and you're going to use the mechanism of, if I get rid of CO2, I can shrink the swelling in the brain. That's about all I can do. If you're going to use ventilatory rate to treat a head injury, you must have capnography in place. Let me back you up 30 plus years when I was in your seat. We were told, head injured patient, back valve mask as fast as you can squeeze it. We got rid of some ICP, but we also put them in an acid-base imbalance, right? We caused respiratory alkalosis. So now with capnography, I can push them to the lower limits of normal capnography readings. If the normal is 35 to 45, I can pull them closer to the 35. But I'm only going to do that if the patient is posturing. So look at the very last one. If I was to rearrange this list, I would put posturing up here. But at the same time, posturing is a very ominous late sign. So maybe there is reason for it being at the bottom of the list. If your patient is posturing, you probably have a dead patient on your hands. Just hasn't all caught up yet. There are two types of posturing that we're talking about here: decorticate and decerebrate. Decorticate, you can remember decorticate posturing. They will pull their hands into their core and they'll turn their feet in. So if I've got a head injury patient who's doing this, they're close to death, and that's called decorticate posturing. If they flex out and turn their head and push their hands out and their feet out, that's decerebrate posturing. They're both bad. Not any one's better than the other one. Some people say if they're still trying to protect their core is a little bit better than exposing their core. I don't buy that. They're both bad. They're both bad. So you'll walk up, they're breathing that crazy breathing rate, and then all of a sudden he curls in like this. It won't be long. It won't be long. Doesn't mean you don't treat them and get them to the hospital, but it's a very ominous sign.
That's what I was about to ask. Like, is that like, you try to give them as much time where he's at?
Oh, if I was triaging, I'd go on. If I was triaging, I'd go on. But if I just got one of them, I'll take him. But what it really means is the brain stem is coming down through the foramen magnum. That's an indicator of brain stem herniation, which is very ominous.
What do you do? Like if you see that?
Go fast to a trauma center. Get a helicopter. Look, somebody launched the bird, right? You can go nice and slow. It ain't gonna make a damn.
Can we see any of this in non-traumatic injuries?
Yes,
So in that posturing,
you could see that. You could see that in a stroke victim.
if you
Would it mean the same thing that the
Yeah.
brain's being pushed out?
I hate to even say this, but I have to say it, and I can't hide anything in this business because I don't want you to ever walk on scene and be surprised. I have seen more posturing in infants than I have adults, and all related to shaken baby syndrome.
so does it always mean that if they're doing that the brain's going
If there's a mechanism to support it, sure. Sure. Now, you can get that posturing with the brain cancer, with a lesion on the brain, a tumor of the brain, whether it's benign or not. It can press on those areas and you get that posturing in late stages of a terminal illness.
Would the only like treatment for that be getting them to the hospital so the kids know the treatment
for it.
There's no
yeah, you can't fix the herniation.
Once it herniates, there's not much that can be done. As far as I know.
Yeah.
As far as I know. I mean, you're talking about a lot of blood. You're talking about a lot of pressure. You're talking about neurological damage. If you did live, the neurological outcomes would not be. Because you're jacking up the vegetable area of the brain, right? The brain stem. The vegetative functions are not going to work right. They may end up on a ventilator. They may never be able to even regain consciousness. So we'll leave that up to the medical ethics on what's going to be life after that. But the shaken baby, if you don't know what shaken baby is, it's when some jackwad will take an infant and slam it against the wall or shake it so violently that it gets the contra coup injuries in the brain and the brain goes to bleeding and swelling. Is that trauma? Yes, that's trauma. Does it cause ICP? Yes, it causes ICP. And when you watch a little infant have that irregular respiratory pattern and their fontanelles are bulging and all this other stuff, it's hard to hold back, Luke. It's hard to hold back. It's really hard to hold back when they arrest the guy who's potentially done that, and the lover goes, "But I love him, you can't arrest him." You know what that's called, Luke? He'll have to cut this from the tape. It's called the golden shit rule. The worse I treat you, the better you'll love me. It's called domestic violence. And when they arrest the perpetrator, you can be assured that the lover will come claw the cop's eyes out because you just arrested him. He just beat you. Yeah, but he takes care of me. Domestic violence is the worst scene you can go into. That one will get you killed. I'd rather go into gang violence than I would domestic violence. Seriously. The domestic violence is more serious. And I don't know how many of you had partners, relationship partners, but there's probably no one in the world that can piss you off more than they can. I've been married almost 30 years, and I can assure you nobody can push my buttons quite like she can. And it works both ways. All right, back to this. Ecchymosis about the eyes. It's not PC anymore, so we'll say ecchymosis. We could call periorbital ecchymosis. Periorbital. Peri means around what? The orbits. You still may see literature out there calling those raccoon's eyes, and they want you to stop that. So, behind the ear, the bruising behind the ear, bruising over the mastoid, we called those battle signs back in the day. If you want to be technically correct, they are now called subaurical ecchymosis.
Why don't they keep the simple name? Raccoon eyes, or whatever, battle signs, whatever.
I don't know. We got to make everything hard. There are no more alcoholics. There's alcohol abuse disorder, alcohol use disorder. Clear or pink CSF leakage from the scalp wound, the nose, or the ear, that indicates to you that the meningeal layer has been ruptured. So if you see some clear fluid along with that blood, something else got torn up. Failure of the pupils to react to light. So I'm not a big pupil assessment person, but on a head injured patient, you really need to do that. When the pupils aren't working right, it indicates some neurological deficit. Period of unconsciousness. Some of these people will get knocked out, and then by the time you get there, they're awake. They may experience amnesia, and there's two different kinds of amnesia. I don't know if you were aware of that. Probably more than two, but if you go to page 1051 in your textbook, retrograde amnesia and anterograde amnesia. Antegrade and retrograde. Retrograde, you can't remember the past. Antegrade, you can't remember the events of the episode. So if you fall off some bleachers at a high school football game and have a head injury, you may not remember your name, or you may not remember your kid's name, but you know what's going on right there. That would be retrograde. You fall off the bleachers at the high school football game, and you can remember your kid, your wife, and everything else, but how did I get here? Antegrade. One not being any worse than the other. Just realize that you get two different kinds of amnesia. Seizures. Why seizures? Anything that pisses the brain off. Very good. Visual, combative. I have often seen people combative and want to fight me, and I'm having a hard time distinguishing, is that combativeness due to drug abuse, or is that combativeness due to a head injury? I'm not going to fight you. If you're well enough to fight me, you're well enough to live. But at the same time, if you're fighting me because you have a head injury, at some point you could degrade, right? You could go downhill. So you got to use some judgment there. If I've got a combative patient, where do they often end up? Or who's often around at that point? Police. This is why they're reluctant to arrest a combative patient. Yes.
How do you say somebody stops, breathing and stuff like that? It's kind of just back up. They get in a car wreck. It's obviously trauma. How do you differentiate between a head injury and somebody who's overdosing, and that's why they're not breathing?
Well, we have an easy fix.
I mean,
No. Breathe for them. Breathe for them until we figure out otherwise.
But when you have bigger issues, with the head injury versus an overdose,
Sure.
how do you differentiate between whether?
But I don't have to. I don't have to because I give them what they're lacking. And if they're lacking the oxygenation and the ventilation, I can just give that to them and figure the rest out later. I'm going to run on the aspect of the mechanism of injury, though, because that's got more secondary and third, fourth, fifth down the line aspects of it anyway. In other words, if the mechanism of injury was bad enough to cause you to not breathe, I probably into the next chapter of the textbook, which is chest injuries. If you're not breathing from a head injury if the patient's not breathing from a head injury upon your arrival, it's probably we're going to even resuscitate, even though they may have a pulse. And I can think of one instance where that happened, and I didn't resuscitate her. She wasn't breathing. When I say she wasn't breathing, she had agonal breath. You remember agonal? She just kind of gasped, and it was bubbly. And I'm thinking two now. They're starting to pop up in my head. I was a young ECA kind of person. I hadn't been to EMT school, but I'd been to first responder school, which gave me the authority to drive an ambulance and help. And I remember suctioning, and I remember the paramedic going, "Do you know what you're suctioning?" I'm like, "Yeah, stuff out of their airway," because their airway's occluded. "What color is that?" "Gray."
No.
Gray. He had a basal skull fracture. He was smacked on Highway 75 by a semi. He got drunk, walked from a bar, kind of like your hypothetical there. You're messed up on substances, and then you take a trauma. This guy was drunk in a bar, starting to sound like a Ron White joke, doesn't it? And he stepped out in front of a semi, and he got plowed over. I don't know why we even attempted anything. The paramedic I was with, she was a little bit hyper. We gotta go, we gotta go, we gotta go. His airway's full, and I just started suctioning. You know what you're suctioning? Oh no, yeah, stuff out of their airway. It's brain. Basal skull fracture. That's why he wasn't breathing. He should have had a sheet. And we rushed him from Calera to TMC as fast as we could go. For no reason. Thought we were doing something though. We were cool. The combativeness, back to that. Man, that's a tough one. If anything's going to put you on the fence, it's like, how far do I go with this? This is what our intent is when the paramedics have drugs that will just kind of knock you down, kind of take the combativeness out of you, kind of take the edge off of it. I don't want you to really run around saying the words chemical restraint. Anytime you use the word restraint, I guarantee you've just thrown a line drive to the lawyers. It's like you called every lawyer in the world and go, "I'm restraining, come watch." Because most of the time restraint goes bad. Whether they have an anoxic brain injury from no oxygen to the brain because they quit breathing and you didn't recognize it, or somebody hogtied someone in face down, prone position, or some cop held somebody down with their knee. Don't need to go into any more detail about that. When you use the word restraint, you're calling every lawyer up. If you're going to restrain a combative head injured patient, I would certainly have med control on the phone, I'd have police officers on scene, and I would have paramedics with drugs available. And realize your big concern here is an airway issue. If you chemically sedate them, you're going to have an airway issue. You're back to opiates, Jonah. If I use my drugs to calm you, they probably also have taken out your respiratory drive. And that's got to be well documented. Lucky for you as an EMT, this is one where you need to take a step back and say, I need ALS and police officers here. I have a combative patient. Let them deal with it. Don't go in at the EMT because you don't have the tools. You don't have the Haldol. You don't have the Versed. You don't have the Ativan. You don't have the advanced airway techniques. You don't have proper restraint training, like a police officer style restraint. If the police do restrain them, they need to stay with you. You just opened up a whole legal thing. This is certainly a combative head injury patient is certainly an ALS call, okay? They need intervention. If you have that at your disposal, some of us don't have that. You may just have to wait till they go out. Never put yourself in harm. Remember, you didn't cause this emergency. Let me go through the rest of this relatively quick, and we'll spend a little bit of time talking about some other head injuries, and then we'll wrap it up. Scalp lacs. The only thing I need to tell you about scalp lacerations are they bleed ferociously. This is a very vascular area. Both face and scalp wounds bleed a lot, and we could have profound blood loss. I've already mentioned to you, car accidents, check the visor, make sure they didn't scalp themselves. There's a picture in your book of someone that's been scalped. It happens. They are also very distracting for you, meaning you will look at that and go, oh my God, and not look at the chest. Hey, you might have been scalped, but you also have a flail segment. And we don't know what flail segments are, but we will tomorrow. But if I got a chest injury down here that's not doing well, and I'm focused on this ugly scalp wound of this 11-year-old girl and going, how is this girl going to, it can get away from you. So we talked about those. There's the battle signs and the periorbital ecchymosis. Linear skull fractures, I'm not too worried about what type of skull fracture you have as long as I know that you potentially have one. So linear just means in a line. Depressed, bone fragment is going into the cranial vault and potentially pressing on the brain. This is where you don't want to put pressure on that and drive that bone even further. If you want to put a bandage around it, it needs to go out here and be stabilized and not pressed directly on the brain. So don't pack that wound, in other words.
Are you always going to have brain swelling or ICP whenever you're...
You'll have the swelling, but you won't get an ICP because it's got room to go out.
I mean, in general, we always have some kind of brain damage that comes to skull fracture.
No. If you remember my story of the woman who shot herself in the head with a small caliber, small underpowered gun, low powered gun, she had no neurological deficit, but she had a skull fracture. Basal skull fractures, the bottom portion of the skull, and it's relatively thin there, it breaks and things fall out. You'll see the bleeding from the ears, bleeding from the nose. The guy that I was suctioning on the highway, that's what he had because his brain was leaking out. This could also become an airway issue. These patients may need to be intubated just to seal off the airway from all the blood that could be running off into the back. And when you're suctioning and digging around back there, you might pick up some brain. But I suspect that's probably a patient you should not be working on anyway. If that skull fracture was bad enough to drive them unconscious, not breathing, just a jacked skull, I'm talking about a rollover with partial ejection and the head got crashed inside the car and then they're sitting back upright in their seat after the event's over with, and you go to touch and palpate and feel and it's just all mush, and then somebody says, they have a pulse. Don't check it. The brain has died. The heart, being its property of automaticity, hasn't kind of caught up with the fact that the brain's gone. And that's bad because you feel like you need to work that, don't you? but they have a pulse, they're still alive. We've gotten so accustomed to saying, no pulse, no respiration, start CPR, that I just need you to understand that when it comes to trauma, the rules of CPR are gone.
So how long would the heart keep on beating?
I haven't timed it. I know, Gus, it sounds bad, doesn't it? I haven't timed it. I don't know, and it probably all has to do with resiliency. How healthy were you? A young, healthy individual is going to last longer than that. How much associated blood loss is there? Is there any associated chest trauma? But, you know, when Kennedy got shot, there was massive blood loss. And when you take those type of wounds to the head, there's blood loss, massive blood loss. Okay, stop and think, how did the blood get lost? Well, the heart pumped it out. So, ACLS protocols, and you guys did BLS protocols, American Heart BLS, and then there's American Heart ACLS that the paramedics are doing. Those protocols don't apply in trauma arrest. If your head injury is bad enough to put your patient into arrest, that's probably not a patient we're going to attempt resuscitation on. And that's a guarantee if it's a triage environment. If I've got more than one patient, I'm black tagging this one and moving to the next one. Not to pick on volunteer services and stuff and these agencies that run out and first respond to scenes prior to the ambulance getting there. All you may have is that volunteer fire service in your community, and the ambulance comes from across the county. I've been around a bunch of that, and what you end up getting is those type of assessment findings, and then you get there and go, stop everything. And it's politically hard to navigate that, because these guys are, they're wanting, they know something needs to be done, and you just kind of come in there nonchalant and go, you can stop, get a sheet. So you got to respect them as well and kind of talk them down, because they're jacked, they're pumped, they got a major trauma, they've been dealing with this, and you just walk in and call it. That's hard to navigate. But it also creates a legal liability, because if they're sitting there screaming, they have a pulse, other people hear it. If the news is there before you are, the news is hearing it. You got to kind of tiptoe around that and get out of that without causing liability. The more assessment findings you have, I've had people hand me an EKG tracing from a heart monitor on these victims with this much head trauma. And you look at that and go, that's a sinus tachycardia with a pulse, and you're not doing anything. I'm doing more than you are. You're not stepping back 10 foot and looking at what's going on here. And I hate to be grotesque, but I've literally pulled back the shirt of a lady and said, you see that running down her back? As she's sitting upright in the car because her head's been crushed. But I had an ECG tracing. It was sinus tachycardia. There was a pulse. Do you see that? And when you see the gray coming down, because the skull was just crushed. Apneic. That apnea is a big one. If the breathing pattern was still there and they were still looking at you and had some responses and they weren't quite you on the AVPU scale, okay. Hank Williams Jr. fell off the mountain. His was out. He had a pulse. He was still breathing. He actually talked to the little boy that went to get help for him. So that's a different scenario than someone who is out. Their heart just hasn't caught up yet. It's difficult to navigate, and you need to well document that, and you better hope you're making the right decision. But most of the time you are. The more you palpate, the more you wish you were not palpating. That's pretty good. That's not in the book, but it's kind of like, okay, all right, I'm done with that. Open skull fractures. That's a Hank Williams Jr. scenario, and a lot of people say they don't know why he lived, and the remoteness of all of that. If you want to talk about a miracle, that was probably one in itself. You guys remember the other day, coup contra coup?
Yeah.
Okay. Here's what kills you once your brain starts to swell. Why does hypoxia kill you? Secondary to the brain swelling. How did we get that?
Because the brain regulates the breathing.
The brain regulates the breathing, and it can't do that job anymore, especially if it's starting to press on the brainstem. So it's not, these are secondary head injuries. This is where you're preventing this. Can you stop the first one? No. Can you stop them from dying of hypoxia? Sure. Hypotension. Blood loss? But what did I say about hypotension along with a isolated closed head injury? You're missing bleeding somewhere else, aren't you? The swelling of the brain itself, that started and will continue for days. There is some research that says, or there's some practice that says, if we give them high doses of corticosteroids, we can reduce the swelling. I think the research says, yeah, if that was running in before they had the injury. But once the swelling's there, there's nothing you can do about it.
If they have cerebral edema, that means they have an intracranial hemorrhage, right?
Most likely.
Okay.
Most likely. It basically means their brain swelling. And there are some other reasons your brain would swell outside of trauma. So I can't just say you're right, but under today's context, you're right. The intracranial hemorrhage, notice they separate those out, but if you get a bruise, does it often swell with a hematoma? Was there some blood loss there? Is it actively bleeding now? No. ICP, we know about that, and then cerebral ischemia because we lost the CPP, and then secondary infections show up. Coup contra coup, tell me what that is one more time.
That's where the brain's hitting either side.
Yeah, it's where it slams forward and then bounces back and injures the back side of it. So you get a 2-for-1. All right, good. How to treat it. I'm gonna teach you a new term today. Support vital signs. Support vitals. When I hear that, or you hear that from here on out, when you're told that in paramedic school, what do you know to do? What's that mean to you, Chas? Support vitals.
Make sure their blood pressure and oxygen.
Make sure their blood pressures, make sure they're maintaining a map. Okay. They didn't hit injuries if like about at least a 65 map. What else? Not only that, you're right. Make sure they're ventilating and
Perfusing,
oxygenating, raising their O2 levels in the blood, and getting rid of CO2 from the blood. Maintain perfusion. Maintain perfusion. That means stop the leaks, control bleeding. And that's support vitals. In trauma patients, when we say support vitals, oxygenation, ventilation, CO2 regulation, perfusion. If you get that, and those are big categories, and there's a lot of tools with each one of those, right? If I say, be sure you ventilate and oxygenate, well, there were whole chapters devoted to that. Dean's starting airway management over there now. That's a 3 college credit level class in paramedic school just on airway control. If I say maintain perfusion, you had a whole chapter on bleeding control. You had a skill day on bleeding control. Oxygenation, you had a whole chapter of airway devices. How to squeeze a bag, how much to squeeze a bag. That collectively is known as support vitals. And these patients are getting so serious in our trauma now, that's about all we can do. Vitals.
part of that, so.
It's part of perfusion, isn't it? It's part of perfusion. Some protocols, most protocols, will not want you to attempt CPR style resuscitation on a blunt force trauma victim. Now, impaled trauma, penetrating trauma, they will. But blunt force trauma, most of them will not want you to resuscitate. So I've already talked to you about all this. I talked to you about these respiratory patterns, Cushing's reflex, so we got that knocked out. I talked about the intracranial hemorrhage and where the bleeding has occurred. So let's go through these individually. And these are kind of ding-ding things here. So let's go through these real slow. Epidural hematoma. It's a brain bleed. Epi, where's your epidermis? It's on the outside, isn't it? So the epidural is outside the dura. It's not under the dura. That would be a subdural. This is outside the dura, so it's an epidural. It's touching the skull. It's out there. Most of these are caused by blows to the temporal region of the skull. I keep thinking of the baseball player, or someone shoeing horses or messing with livestock and they get kicked in the side of the head. Or if you want to punch somebody in the head and it be pretty severe, you're going for the temple. That's the thinnest area of the skull. And it also has an artery underneath that called the middle meningeal artery. Blows to the side of the head often result in epidural hematomas. I'll go right back to it here in a second. Epidural hematomas. There's a lot of information here in the next 20 minutes, and I'll be as honest with you as you are with me. I really can't apply this in the field. So, according to your textbook, and I'm not going to disagree with it here, but I'm reading it just because there's so many symptoms here, this gets confusing. And you can go back and read it yourself. This is on 1049. This patient presents with an immediate loss of consciousness followed by a period of consciousness. And now you're going to hear a new term called lucid, L-U-C-I-D, a lucid period. Lucid means you're with it. So this patient is going to be unconscious when it happens, wake back up, and then go back into unconsciousness. As the ICP increases, the pupil on the side of the hematoma becomes fixed and dilated. Death will follow rapidly without surgery to evacuate the hematoma. Why is this thing so fast? Why does this bleed get you so fast? It's an artery, so it bleeds faster. We already know this from our soft tissue lecture. Okay, so that's an epidural. And the ding-ding question on this is unconsciousness followed by a lucid period. When you see the word lucid in the test question, you better be looking for an epidural. Do not confuse this with the thing they give pregnant women in labor, epidural. Technically, location is the same, but the mechanism's totally different. An epidural is a way to anesthetize the spine below the area of the injection site. So they put numbing agents epidurally that will numb the spine from that point down, not to be confused with the hematoma. The next one is the subdural. Venous bleeding occurs. So with that, it means it's going to be what? Slower. So S for slow, S for subdural. More common, usually from deceleration injuries, so slamming into a bridge.
What was the main reason for epidural?
Artery.
Yeah, like this was from whatever.
Oh, linear skull fracture. Blow to the side of the head. This is from deceleration. This is almost a coup contra coup kind of thing. This is the one that's so slow, that can be so slow the patient doesn't want to go to the hospital but never wakes back up. So if you see the epidural, the one on the previous slide, you're pretty alert to, hey, this thing's going to progress rapidly. It knocked you out, now you're back. That's my telltale sign. We need to go. This one, you're going to be like, well, I don't know. Should we? And the answer is yes. Yes.
So what would be the main, like, defining between this and like a concussion when they, they get knocked out and that way?
Yeah, I'll talk about those, and if I don't answer that question then we'll readdress it. So keep that open, okay? We're going to leave that question open for a minute. Well, one of the points I want to make about this is when they go into CT scan to see if there's a bleed in the trauma center, these may be so slow that they don't show up immediately. Or if you don't have a really trained eye, if it's not a radiologist interpretation, maybe it's just that family practitioner doctor looking at it going, I don't see anything, but it's the only fifth one I've ever seen. That's why they send this thing off to a radiologist, and they can read it and like, hey, look over here, slide 42, we got a little spot. We need to put those in the unit and evaluate them and observe them for more of a bleed. And then they'll repeat those CT scans to see if they need to surgically intervene. Some of it, they just may pause and say, you got a small bleed there, but it's not moving. You'll be fine. So we'll take serial CAT scans or imaging. Guess what your book says on 1050? People taking blood medications or those with a history of alcohol use are at higher risk for subdural hematoma. This is caused by atrophy of the brain. So if you drink too much, your brain shrinks. That's called atrophy, which allows your brain to flop around in the vault a little bit more. Any questions on this one? So let's look at intracerebral hematoma. Now this is wow. Okay? We're bleeding not in the meningeal layers, like right in the middle of the brain. We have blood creating a blood-filled tumor inside the brain tissue itself.
Is the definition of tumor just anything like not supposed to be pretty much?
A tumor is just a growth. Your book doesn't get to the big one, but I'll mention it. Blood-filled tumor in cerebral tissue. The tissue has ruptured, it's bruised, started leaking in there, caused a hematoma. Subarachnoid hemorrhage. So here's another head bleed. Subarachnoid. So if they do a spinal tap and they find the blood, we got meningeal irritation. Do you guys know what meningeal irritation looks like in a patient? Whether it's caused by meningitis like the infectious agent or it's caused by trauma. When you irritate the meningeal layer, you remember the term nuchal rigidity? Well, I put it on the board. Nuchal rigidity, stiff neck. So if you ask the patient to touch their chin to their chest, they can't do it. without pain. Now, if you had a trauma patient, you wouldn't ask them to do that anyway, and that may be the problem with the pain, so yeah. But nuchal rigidity, stiff neck. They also can't flex their leg out if you have them do this, because it hurts in their lower back real bad. That's a sign of meningeal irritation. You can irritate that through infection, or you can irritate it with blood. If blood gets in the meningeal layer from this subarachnoid hemorrhage, you know where the arachnoid is? That's the middle layer underneath that. If we're bleeding in the meninges itself, that's what we're talking about here. This is bleeding inside the meningeal layer itself. Not in the brain, not outside the meningeal layer, but inside the meningeal layer, subarachnoid. Sudden severe headache. What does that look like? What does that sudden severe headache or rupture of an aneurysm remind you of? A stroke. What kind of stroke? Hemorrhagic. If the rupture of the aneurysm occurred watching Price is Right, it's on the medical side. If it occurs because you fell off the stepladder, it's on the trauma side. The result looks the same. All right, so let's go to your question here, I hope. Concussion. There is no universal definition of concussion. Well, that's great. What's a concussion? Just, it ain't normal. It ain't what it was. We could ask Troy Aikman what a concussion is. We could ask Brett Favre what a concussion is.
One dude they made a movie about.
I'm not familiar with that. Some of you probably had concussions. I've had one or two, I think, if I remember. Falling from a horse and having a tree fall on me. By the best definition we can come up with, temporary loss or alteration of part or all of the brain's abilities to function without demonstrable physical damage to the brain. So on imaging, we don't see anything. But you're seeing double vision. My concussion, I had double vision. My concussion, when I tried to get up off the floor, because I was laying there watching TV, the TV split into two, and I was like, whoa, something wrong. My wife's like, I told you not to ride that horse. But your sister wanted me to. Don't ride a horse. There was no change to the brain structure that was visible. So what do they do with these NFL players now when they put them under, and I hate the term, concussion protocol.
They're just watching for them.
They go back there, they do a 12-point cranial nerve exam, they make them do an astigmatism, or not an astigmatism, but I can't think of the word right now. Do your eyes follow? You know, can you feel, can you touch, is there anything visibly that's not normal about you? And they've got baselines on those people. I've noticed after watching that, and after it's become a big deal over the past few years, that you're as good as the people in the booth, aren't you? The people upstairs told them to pull him out of the game and put him in there. When they do the replay, you're like, yeah, yeah, I could do that. I could tell you to go. And when your head bounces 4 times off the turf, yeah. When your helmet gets knocked sideways, yeah. Some of you played football, and supposedly they're tracking it now through high school and up through college. And if you get so many, you're done. Which leads me to believe that if you're really good, they're probably not going to track it near as well. But anyway. 90% do not lose consciousness. So are you cool with concussion? We got all that. Contusion. There's a difference. What is a contusion as far as you know it? Bruise. So now if I were to image the brain, would they see something? Yeah, they would see a bruise. Depending on where you're at or where it's occurring, it could be permanent. So these are the people, if it was a football player, they'd be out. They'd be out. They'd be done. No more. But it happens. It is the actual bruising of the brain. If you get a bruise to your thigh, what's happened to that muscle? You've ruptured some cells, you've destroyed some cells. That same thing's happening in the brain.
But I guess the brains can't heal.
It depends. If you don't die first, a lot of times not. Neurons heal slow, if they heal at all. Let me tell you about another one that can play off your question a little bit. And your book doesn't mention this one, but I'm going to mention it. And this is the bad boy of head injuries. It's abbreviated, Luke, DAI. Dead on arrival. DAI, diffuse. When I say the word diffuse, what's that mean? Everywhere. If you got a diffuser in your home throwing out scent into the room, it's pushing it all across the room, right? That's what a diffuser is. So if I have diffuse axonal, AXONAL. Do you remember from our neurology lecture, we have axons and dendrites? You take two neurons and how do you hook them together? Axons and dendrites. Little tails, little tentacles that hook one to the other. The gap between them is called the synapse, the synaptic cleft. Remember? Diffuse axonal injury. So you have taken all the axons and dendrites and pulled them apart. How does that patient look?
What's the eye?
Injury. How do you think that patient looks? They're you on the APU scale. This is a blow to the head that's so severe, or a trauma to the head, or energy to the head so severe that it has basically pulled the breaker box apart. Go to your home's breaker box and just imagine going in there and just ripping all the wires out. Just in one big blow. That's what's happening to the brain. All the hookups that were there are now unhooked. These are vegetative type patients. Probably will not recover. There's no surgical intervention that can hook those things back together. Instead of the brain being a collection of connected neurons, your brain is now a collection of disconnected neurons. And it won't work. It won't work. Miracles happen. And they may still vegetatively be alive. They still may have vegetative functions. But it's probably the worst type of head injury you can have because there's no surgical intervention hope at all for it. Not that there is from the other ones. Questions so far?
What's the difference in a brain contusion
Brain contusion and a
TBI?
TBI is just going to be the broad category. So if I put traumatic brain injury, I would put underneath it, you ready? That. They're all under that one. Everything we talked about today is under the big heading TBI. Good question though. Because when we talk about stroke, what's the other word for stroke? Well, I mean broad categorically speaking. If TBI is traumatic brain injury, what is stroke? Huh? Yeah, non-traumatic brain injury. That's how they really want you to talk about it. Traumatic brain injury, non-traumatic brain injury. Boy, don't they look the same in so many other areas though? It's all the mechanism or not. All right. So the second part of this chapter is spinal injury, and this will not take very long at all. Some take-home messages from the spinal injury lecture. Your textbook still talks about backboards, C-collars. It talks about taking someone with suspected spinal injury and have them standing up, and you put a backboard behind them and taking them to the ground. That's called a standing takedown, so you protect their spine. We used to teach that nonsense, and I hated it when we taught it. And the only time I ever done it in the field is if the news was there. Because I was of this concept: if this patient's able to get out of their car and walk around, they don't need me to tie them up. But the textbooks at the time, and yours has still got hints of this going, oh, but they could have a spinal injury and die. They could be paralyzed for life. That's all true. But the mechanism in protecting them was not the preferred method. There is nothing more injurious to an injured spine than log rolling. You know how much it pains me to see you guys practicing log rolling and the person at the head's got control and we log roll them up and then put the board under them, roll them back down? There is nothing more damaging to an already injured spine than that technique. The best way is to scoop them up with that scoop stretcher that you saw, the thing that just scissored underneath them and picked them up in position found. Outside of that, probably just picking them up by their shoulders and pelvic and move them over. Coordinated, of course, is better than rolling them up on their side. C-collar application. C-collar application in an already injured cervical spine has been demonstrated under radiographic imaging to cause distracting injuries to the spinal column, especially if the C-collar is improperly sized or applied. It actually pulls it apart. All research is showing under empirical visualization, is like we put them under imaging and we see what's happening, that doing nothing is better. Who protects their spine better than anyone? Themselves. So when it come up to an auto accident, you should be saying, Riley, you hurting anywhere? No, I'm kind of scared, but can you get out of the car? You think you can get out of the car? Yeah. Well, I want to be here in case you can't. I won't let you fall. If you start hurting, tell me, but let's see if you can get out. Self-extricate, put them on the stretcher, lay them back, continue your assessment. Okay? If she's unconscious, I need to move her. I'll put her on backboard, move her with the backboard, and then get her off of it. There's the rest of that chapter could go away if we just took that all out of practice. That's a new textbook. Why is it still in there then, Brandon?
The news is watching.
The news is watching, yeah. And it still kills me, like on the NFL, when somebody gets injured and they have to cart them off the field, they're still putting them in all this stuff. Just because the NFL's doing it doesn't mean it's right. And hopefully it's just to get that big old heavy boy off the field too. And as soon as they get them off the field, they let them out of it. But it sure looks like they wrap them up tight, doesn't it? With straps and blocks and things. And I'm looking at that patient. I think now they're a patient if EMS is there. And they're still in their full football protective gear. And they're all tied up to this backboard. And I'm like, I couldn't work on him if I had to. I can't even get to the chest. Can't get to the airway. I'm probably not going to strip him down in the field, but I bet they did DeMar Hamlin, don't you? I bet DeMar got his stuff taken off because they had to apply the AED. I don't know. Here's what you need to know about spinal injuries. They can cause paralysis. Yeah. Loss of motor function. Yeah. Loss of feel. Yeah. And here's the big one, spinal shock. It's another category of shock called spinal shock. And what spinal shock is you're somewhere in your spinal cord, it has taken a blow and it can no longer transmit down to the other organs, namely the vessels. And so your blood vessels that are under nervous system control to control the diameter lose that nervous system control, and what do? They open. If I have a 6-liter container and it opens up to an 8, I've in theory lost 2 liters of blood. Even though I haven't lost any blood, I have what's called a fluid container mismatch. My cold's getting the best of me. We're gonna have to wrap this up pretty soon or I'm gonna be snotting all over you. Fluid container mismatch. Well, part of your reaction would be, when you get a paramedic there and put a bunch of fluid back in the container and make that 9-liter container now have 9 liters of fluid in it. Well, there's a problem with that. If that nervous system regains control, I'm gonna push all that fluid to the lungs. You won't have to worry about that as an EMT because you can't give fluid. You're gonna have to treat for shock. You're gonna have to treat for shock, even though they haven't lost any blood. So the test question will look like this. You got a mechanism of injury that's indicative of spinal cord damage. You have warm, dry skin. That's the telltale sign. What does shock usually look like? Cool, clammy? You're gonna have warm, dry. Not up here, but down here. So like their arms and their shoulders may be cool and clammy, but their legs and torso may be warm and dry. Why? Because the blood gets to go out to the surface, not pulled in. So what's happening in spinal shock is your body knows that there's a drop in blood pressure through the baroreceptors. It activates all those compensatory mechanisms. Remember those from back in the day? Sympathetic, transfer of blood out of the spleen, adrenaline dump, alpha 1, beta 2, renin-angiotensin-aldosterone system, all these things to compensate. So the top part of your body's trying really hard, and the bottom part of your body can't do anything about it. And that's the definition of spinal shock. Outside of paralysis and loss of sensation and motor function, your other concern is spinal shock. That's the one that'll kill you.
The real cause of the shock is it dumping that extra 2 liters into that open space.
The real cause of that shock is I don't have 2 liters of space.
Okay.
I've created a 2-liter space or a 1 liter, whatever the case may be. And then secondary to those injuries that are life-threatening, we have a quality of life issue going on after that. So you can have spinal cord damage to the point where you're riding a wheelchair, sucking through a straw for the rest of your life. Think Christopher Reeve. Christopher Reeve was the old Superman guy, loved to ride horses, got thrown from a horse or ran into a tree or something, I don't remember, but it messed up his cervical spine. He had spinal cord damage. He couldn't breathe because his chest wall muscles were paralyzed. The EMTs or paramedics were breathing for him. He never regained that, and so they cut a hole in his neck and put him on a ventilator. And he drove his wheelchair around by manipulating a straw that he carried in his mouth. And he eventually died of pneumonia, complications of pneumonia secondary to being on a ventilator all your life. Just, well, I don't know. I mean, you'll make that decision if you're ever at that point, but that's the problem. Putting him in a C-collar backboard was not going to prevent that. Fannin County, Oklahoma, Fannin County, America, not Oklahoma. Real close. The river turns right. I think at one point Fannin County was in Oklahoma. A girl in a remote rodeo arena was thrown. She's like 17 years old. She was thrown from a horse. She was riding barrel horses. She was thrown from that horse into the steel arena pen, the fence of the arena. It's a long response time. I'm having to ride. Somebody else was driving. It seemed like we were riding 15, 20 minutes, and very well could have been in Fannin County. If you're located in Bonham and you got to run the entire county, you could have 20, 30-minute response times. You can have response time so long that you forget the siren's running. I've opened the door and like, oops, siren's still on. You just forget it. It's running. How do you do that? Well, it's called sensory fatigue. Anyway, back to the story. That response time, when I get there, that 17-year-old girl is still face down in the dirt of the arena. What do you know now? When I'm walking up, I was like, is she dead? Because if you're still face down from 911 call to the time I get here, oh my God, something serious is going on. I get up there to her, I look at her face. Why not look at her face? I got my hand on her back and I'm looking at her face. I can't tell you. I do not recall. Remember, it's been over 20 years, and I just don't remember where it was at. Huh?
I didn't want to touch her.
Just left her there laying face down in the dirt.
Yeah, there wasn't a lot of people around her. Somebody had called. I get there. She's still face down in the dirt, but I'm looking at her face with my hand on her back. What am I doing? ABCs, initial assessment. She's breathing. And she's sniffling, crying, and she's done a lot of that because there's a lot of mud on her face and a lot of snot.
She's still conscious?
Oh, yeah. And she says, I have so much pain in my back that I can't get up.
Did y'all
Okay.
log roll?
No. No. But if I had followed that stupid thing, what should I have done? Log rolled her onto a backboard. My partner was like, are we going to log roll her? And I'm like, no. I said, so we start you got pain in your back, anywhere else? No, just in my lower back. I said, okay, I'm going to walk my hands down your back. You're going to tell me where it hurts. I get to way low lumbar, like waistline. There you go. There. No. Pelvic region. Her posterior pelvis is extremely tender to palpation. Not going to log roll her. Not going to put that on a backboard. But what am I now suspecting?
Spinal injury?
And pelvic fracture. And neither one of those are good. Maybe one's even worse. If I got a pelvic fracture, it's not stable. Do I go pressing on the pelvis to see if it's stable?
No. Yeah, wait, so in that situation, you would not use a pelvic binder?
Well,
Probably.
I didn't have one.
Yeah. So
Yeah, those are new.
it wouldn't matter.
Well, no, not really, but didn't have one. They're new to the field.
How did you move her? What did you do to move her?
Sterrett is all, he's like, man, I got to hear this. Well, you're right, I didn't have a pelvic binder. You're right, I was worried about spinal cord damage and or pelvic. Now, the back of the pelvis is what? What forms the back of the pelvis, the posterior? Yeah, the sacrum. Are there spinal nerves coming out of the sacral region? Yes. So even if it wasn't like lumbar, I still got 7, 12, 5, 5, 4. I'm down here in the 4. There's, and I don't mean to be any weird way about this. Those nerves that come out of the sacral region innervate the pelvic floor, like the sphincter that closes the anus, like the sphincters that control the bladder, like the nervous system input to the genitalia. She's a young girl with could be major lifestyle changes based upon this injury. If not plain out life-threatening, because mismanagement of this could rupture one of those pelvic arteries and cause some major damage. Now, you were probably told Monday, and if you weren't told, it's because Emily didn't think to tell you. Coming from a trauma center, all trauma victims need to be naked. You can't treat what you can't see. So Sterrett's next question is, did you cut her clothes off, Brandon? I did not, because she was wearing her pelvic binder.
Oh, her, yeah.
Jeans. Jeans and belt. They were tight. And then that came to mind. It was like, that may be the only thing stabilizing her. I'm not cutting that off, and I'm not cutting it off anyway, because she is a minor. Is it a life threat? Do I need parental consent? I don't go with the parental consent. I think this is a life threat. Anybody's laid here this long, inability to get up, neurological damage plus vascular damage, we're going to go with this. That may not even have been an issue. I don't recall it even crossing my mind. Sterrett's next question, how'd you transport her? Face down. Face down. So we went all the way to the hospital, face down.
So, like,
Scoop stretcher.
Scoop stretcher, okay.
A scoop stretcher. And there were people that didn't even carry scoop stretchers. I never understood why those went away. Somebody in the head office thought that's another expense. They're hard to clean. They're stupid. You know, they got 50,000 backboards, but they don't have a scoop stretcher. In my day, scoop stretchers were not spinal immobilization. Oklahoma would use a scoop stretcher. Texas would not. That we're talking 1989.
So what would you have done if you didn't have a scoop stretcher?
I would have probably used a sheet the best I could. I was not going to log roll her. I would have tried to work a sheet under her and done the best I could. Scoop stretcher made it so nice. So we transported face down. I didn't attempt to roll her on her back. I completed my assessment. She said she had some tingling in her feet or something. Her vitals stayed stable. Nothing. I didn't do anything. She needed x-rays to see actually what was going on. At the ER, they disrobed her. Okay, they got her naked. And now she's in an emergency room. There are nurses and there's a doctor there. Well, the doctor puts a glove on, and guess where he goes?
We're about to see if she's bleeding internally.
The first thing he checks is sphincter tone.
See if it's relaxed.
He's seeing if her anal sphincter is still clamped down. If it is not clamped down and she has lost sphincter tone, then she goes to neurology immediately. This young woman could potentially end up wearing a colostomy bag for the rest of her life, because otherwise it's just going to run out of her. And it could have been more serious than that. She did not go to a trauma center. I took her to a hospital with x-ray and said we can make the transport decision from there, because the trauma center was so far out. And there was also bad political blood about taking anyone out of the county because they wanted those people to be seen locally. And if I'm not mistaken, I took her to Greenville. It wasn't at Bonham Hospital. It was like to Greenville or something. She'd been laying in that position for a really long time. There's a little bit of thing there. She'd been at a level 1. Yeah, sure. Anybody should be at a level 1, right? So there's a little bit of, hey, wait a minute. We're almost an hour into face down and we don't know what's going on here. We probably need to get her, at least know what we're dealing with. But no, didn't cut it off. And it was for that reason that I did not. And it's been Emily and I kind of go back and forth on that a little bit. I didn't know. I know she had sphincter tone. That's as far as I knew. That's as far as I knew. But it's just one of those things that you never know what you're going to get into. And the people who write these books, or the people who are armchair quarterbacking back from an office somewhere, looking at your report going, why didn't you never ask? Why didn't you cut her clothes off? Primary reason, it could have been stabilizing pelvis. Secondary reason is, oh, come on. There was no blood loss. What would be the benefit of exposing her? Is there? With no blood loss, is there any benefit of cutting her clothes off? No. No. And there probably was some benefit leaving it on, especially if she had a pelvic fracture. So I get it. Sometimes I think we're reluctant not to disrobe people because we just don't see it. But at the same time, you can't treat it if you don't look for it. So not that many people got that naked. Don't let it come across that way that we got to have every patient naked. I worked with a guy who probably got too many people naked. I'm like, dude, really? Come on. But you'll work CPRs, you know, where people have collapsed on the toilet and their pants are around their. I mean, it's just it's kind of a gross world out there. And can I have that sheet, please? And cover them up. Cover it up. But if you're working a CPR and you need to check for a femoral pulse, right there next to the groin, and press on that femoral artery to see if those compressions are good. It's a great way to determine that. If there are great compressions with no femoral pulse in a CPR, that's the result of a trauma, you probably lost the blood somewhere, haven't you? You don't have enough blood to generate a pulse. But I don't want you doing CPR on someone and having pads on with a bra still in place as well. So I don't know why we're diverting on that, but anyway. Do you have a question? Oh, okay. Do y'all have anybody else have any questions? I will eat and I will look at your grades, and here's what I'm going to do. Now we got to be in agreement on this, okay? I have no problem with you taking that test again.